Welcome everybody to the Health Resilience webinar hosted by the Health Engineering Task Force. I'd like to draw your attention to the chat. Please feel free to enter any messages you'd like into the chat. And throughout the presentation, if you have a question, please enter that in the Q&A. And you can actually vote on questions that you want to get asked so that we don't have any redundancy. So with that, I'm going to turn it over to one of the chairs of our Health Engineering Task Force, Commander Steve Sauer of the Public Health Service. Steve, over to you.
Thank you, Kathy. Good afternoon and good morning to everybody. I just wanted to thank everybody for joining us today on the Health Engineering Task Force webinar. And today's topic is going to be on health resilience. And we have a pretty interesting panel today with Dr. Nino Kharaishvili, Matthew Holmes, and Craig Miller. And we will, without further ado, we'll turn it over to Nino. Thank you.
Thank you, Steve. Thanks, Kathy. Good morning, good afternoon, good day to everyone. We are very thrilled to be here, and I wanted to thank Sammy and Health Engineering Task Force and the team. We're happy that we have a chance to present health resilience to this great audience and talk a little bit about how we are approaching this concept and what we are doing at Jacobs to improve health resilience in the United States and internationally as well. I have two of my co-workers, Matthew and Craig, with me today, and we will do a quick introductions. I would like to start with myself. As Steve mentioned, I'm a medical doctor, and I have been consulting the federal government in the United States for most of my career, and my area of practice and interest has been infectious diseases and the health system strengthening, health system resilience, preparedness, as well as simulation exercises, program evaluation, etc. And I've done this in the 40 different countries around the world, and I've amassed quite a experience doing so. So I will be more than happy to share my expertise and lessons learned. And with no further ado, I would like to introduce Matthew Holmes and then Craig Miller. So Matthew, please take over.
Thank you. Just to make sure I turn the microphone on. It's normally the first mistake of the session I'll do. My name's obviously Matthew Holmes. Hello, everyone. I'm an architect by background. You can probably tell I'm originally from the United Kingdom and have worked principally in healthcare, delivering healthcare architecture or healthcare projects around the planet. So spent a lot of time in mainland Europe, France, North Africa, currently actually in the Southern Hemisphere, down in Australia at the moment. I lead for Jacobs their health infrastructure arm, so really any sort of built form in healthcare, and obviously being a global firm, that's coordinating with all our teams sort of globally and around the planet. And I'll share with you today a little bit of some of, as Nino said, some of sort of the responses that we've undertaken to support resilience across those projects sort of around the planet. And I'll pass over to Craig.
Greetings, everyone. And I use greetings because I know we have multiple time zones. So I'm Craig Miller. I'm a Global Solutions Director for our Health Operations Advisory. And I'm a structural engineer by education. And I have been involved with healthcare operations as well as capital programs now for over 25 years. And been across the country working on a variety of different healthcare programs and for different systems. And my field of expertise is with the operational planning, business models, as well as capital programs for a lot of our healthcare clients. And so I'm looking forward to speaking later in the presentation and sharing with you some of my experiences as it relates to resilience in health, some real exciting stories to tell. And so thank you.
Thank you, Matthew. Craig, let's dive into the presentation. Let me advance the slide here. So let me quickly walk you through the agenda. we will do the culture of caring moment. That is the habit and the practice that we have at Jacobs in our company, and that will be a scene setter for our presentation. Then we would like to quickly, very briefly mention how our health market is structured in a company. And lastly, we will dive into the resilience introduction, because this is a term that has been kind of thrown around, and people ask a lot of questions what it is and how to understand resilience. Then we will talk about our approach at Jacobs. How do we approach resilience? What is our framework? And lastly, as Matthew and Craig mentioned, we will bring the case studies from around the world to highlight our approach and in practice. Like, one is to have a framework, and the second question is like, how do we implement this, and what are the different types of the programs or approaches that we use with our partners and help them to strengthen their systems and make them more resilient. With that said, let me do a little bit of the culture of caring. And what this means, we at Jacobs, with every meeting that we have, we select a topic of interest that is very critical and important and kind of affects all participants of the meeting. And we specifically selected this topic. It's what are the urgent health challenges for the next decade. And I wanted to pause everyone and kind of challenge everyone to think through all the list that is on your screen. And I will also walk you through a couple of those. So World Health Organization 2 years ago, now probably 3 years ago, in 2018 to 2019, they got the global health experts together, and all of them put their heads together and talked about like what are the pain points for the health systems around the world, including the United States. And they highlighted the concerns that are not addressed, even though collectively we are all doing a lot of things to improve health systems, but national frameworks, local, etc. But there are still a lot of challenges. Remain in the world. And just to highlight a few, elevating health in a climate debate, and that is a very near and dear topic to my heart. And why I say that, I'm a big proponent of One Health concept, which means that all species in the environment are connected. So it's a human health, animal health, and environment. We are all connected, which means that disturbances to one segment will affect the others. So disturbance in the climate change affects the population and health of population. I can go on and on, but I don't want to take too much time in there. Making healthcare fairer, like pointing out this, as we saw in the midst of the pandemic, it highlighted how health equity was not the thing, that we didn't have health equity even in the United States. So making healthcare fairer, accessible to all population, to all parties, I think it's very critical. Even stopping infectious diseases, preparing for epidemics, I think that does not require the explanation. I worked in this field for my entire career, and I can tell you that in the past 2 decades, we've seen a lot of pandemics. Some of them were more prominent to public, so we got a little more limelight, but nothing was as bad as compared to COVID-19 pandemic that we are seeing right now. And then, for example, investing in people who defend our health, we also saw that we had a problem with our healthcare workers being overworked, burnt out. So all of these challenges that we are listing here, they are directly or indirectly linked to the health system resilience. So that's why we chose the topic to be highlighted here. And I also urge you and challenge you to think about those topics, and you can go to the website and peruse the link to see like what can you do through your career, through your work to address those challenges. So that's my culture of caring here. For the next slide, as I mentioned, I would like to introduce it a little bit, like how Jacobs Health Market is structured. We have 3 segments that we care about, and I am Global Director for Health System Governance, basically, which means that we are working with the national governments, with state governments, international governments, healthcare agencies, organizations, and communities around the world to implement new pathways for effective decision-making, resource management, operational environment, which includes resilience, health equity, sustainability in health, and etc. We focus on the system structure, policy frameworks. We focus on the oversight mechanism and financial models, and that's my domain of expertise. As Matthew mentioned, he runs our infrastructure branch in Jacobs, and we work with health system operators, academic medical centers, and in this domain, we basically provide everything in the kitchen sink from A to Z. We do the design, we do architecture, we do the planning, we do commissioning or construction, project management, commissioning, etc. So we have end-to-end solution set that we offer to our partners, and we are delivering innovative facilities that are sustainable to operate and that enhance economic, social, and environmental outcomes. Lastly but not least, Craig Miller runs our health operations advisory branch, and he and his team work with healthcare executives, service providers, as well as corporate partners. So we help our partners to implement projects and programs that are patient-centric, people-centered, and improves the accessibility to healthcare while making the services, healthcare services, affordable and integrated. Again, we provide strategic operational digital advisory and implementation support to improve the quality of care, as well as optimize the service delivery to benefit the patient and healthcare workers. The next slide, I would like to deep dive into the resilience. And as I said, this is a term that has been discussed in many different other markets, but when it comes to health resilience, it's a little bit a newish term. So I would like to take a moment and walk you through the more different schools of thought and what it means in the health market. So health resilience has three different distinct segments, and it all started back in the day with individual or personal resilience. And why I say this, this term mental resilience or personal resilience was coined by American Psychiatry Association back in the day, because this term was used about being able to adapt, then overcome adverse event and thrive afterwards. So it was really big about personal coping mechanisms and how to use those coping mechanisms to survive in different scenarios. Then it evolved, and then another component to the resilience was added, and that's a community resilience, which basically is the ability of community to use assets to strengthen public health and healthcare systems and to improve communities' physical, behavioral, and health outcomes. And that's important. However, the topic of our conversation today will be health system resilience. Although it has a tiny definition there, I didn't want to go write a lot of stuff here because we will be talking about the health system resilience throughout this entire presentation. But basically, health system resilience is the ability to prepare for, manage, and learn from the shocks and adverse events. And health system resilience is in United States case, that would be at the level of the state health departments or the national federal government. But at the same time, we can talk about and take this model and apply to the hospital systems as well. So there's multiple application of this. I've given this talk many times and to the different audiences. And even when I talk to, let's say, to CDC and their people, they always ask me this question, and this term is giving people a pause. They say, does this sound very similar to emergency preparedness? Is this an emergency preparedness? Or is this a risk and vulnerability assessment? Or does it have a sustainability in it? Is this the health system strengthening? So I had many debates over this, and basically health system resilience is all the above. It's not the one event. It unites emergency preparedness, brings in risk and vulnerability assessment, so we forecast and anticipate what shocks will be affecting the system and how it affects the system. And we also need to design the programs that help the system to be stronger, and that will be the health system strengthening component, and those strengthening components need to be sustainable. So I love this definition on the right-hand side of the screen that you're seeing, and that came from one of the policy publications. Resilience is seen as a boundary term that sets a crossroads between politics and science. And resilience has a function to build political consensus and bring science in, thus allowing the existence of multiple agendas. I love that quote, because resilience, in order to make systems resilient, you need to have the political buy-in, right governance and leadership, and you have to have technical capabilities as well as operational plans and policies to make it work. So all of these multiple agendas need to coexist and coexist seemingly in order for anyone to claim that their system is resilient. That's why we think that resilience requires quite attention. It's a very multifaceted approach, and that's what we want to dive in the subsequent slides. But before I do that, I want to introduce you to the couple of different schools of thought. So everything started with World Health Organization. There's a school of thought that they are championing, and their resilience definition is related to processes and skills that result into good health outcomes despite negative events, serious threats, and hazards. Their framework is 12 core competencies, and it's around preparedness, divides them into governance, capacities, and resource use. They had the multiple experts come together to put that framework out, and that's what WHO is championing. And then we have Johns Hopkins University School of Public Health and the Center for Health Security. They have fantastic researchers there, and what they did, they did a meta-analysis, a scoping review of, 1,000 different publications and articles. And each of those articles were talking about the components of the resilience for the health systems. Basically what they did, they combined, racked and stacked all these different capacities and came up with a list of 16 technical areas that the health systems need to have in shape in order for them to claim that they are resilient. So those 16 capacities talk about altered standards of care during emergencies. They talk about the post-event recovery. They talk about financial mechanisms for the system to survive the shock, committed to continuous quality improvement, commitment to the continuous quality improvement, and etc. So this is a very complex framework that they put out. Lastly, but not least, I want to talk about our neighbors in the north. Public Health Ontario did a massive focus interview. They polled 130 participants from the different health departments across Canada, and they generated the qualitative data with essential elements and kind of determined the linkages between those elements. They identified 11 elements, with 10 of them being distinct pillars, but one of them being cross-cutting across all pillars, and that was governance and leadership, which kind of again highlights back what I was mentioning, that political buy-in and leadership is very critical when you talk about the resilience and building resilient health systems. So now I would like to pause, and I gave you a lot of background information. What is resilience? How people view resilience? But this is we are Jacob's team, and we have our approach, which is basically rests on all of the schools of thought and some more. And we came up with our resilience, health system resilience framework that I would like to proudly present to you. So our definition of health system resilience mirrors the WHO's and Johns Hopkins' definition of health system resilience. And we define it as the capacity of a system to absorb, adapt, anticipate, and transform when exposed to external threats and/or forecast shocks that bring about new challenges and opportunities, and still retain control over its remit and pursuit of its primary objectives and function. Basically saying, like, your health system need to deliver what they need to deliver, which is the care to population, despite what shocks and adverse events they are exposed to. And I'm sure we all agree that it is a very critical component for any health system. Like, you bring the outbreak, the health system shouldn't crumble. You have the different challenge, you have environmental challenge like earthquake, the system shouldn't crumble. All of this stuff that we define through our vulnerability assessments, but basically whatever the shock is, whatever the adverse event is, system needs to function. And that's what the resilience is. Now, I know this is a busy slide, so I apologize, but bear with me. This is our wheel of resilience, as we call it. And it's a competency-based model, what you see on the screen. So our framework is organized into 8 solutions-based core competencies. And we provide everything that is listed here. And we believe at Jacobs, all 3 of us believe at Jacobs, that in order for health system to claim that it's resilient and can withstand the shocks, they need to have all of these 8 core competencies. And it's also not very straightforward. I've never seen a project that delivers only one competency or delivers only one segment. And we will talk about this, and Matthew and Craig will highlight it. Lots of projects that we are doing deliver multiple competencies at the same time. And that's what makes this wheel or use of this framework fun, because you can select, it's like a Swedish menu, you can select what competencies you want to address and design a project accordingly. So we start with the competency 1, and we start at the high level. As I was mentioning before, none of the resilience project will survive in the long term if you don't have the right policies, legislations, and plans and leadership to govern all of that. The second competency is the very critical one. It's a communication and coordination mechanisms. And you can have the plans, but if you cannot communicate the plans, then what's the point of the plan? You can sit there and collect the dust. And number 3, the healthcare infrastructure. Matthew will dive into this more deeper, but as I said, healthcare infrastructure is a critical component for making systems resilient. Number 4 competency is logistics and supply chain. I will just highlight here that we saw how even United States health system was scrambling when we had the challenges with the supply chain at the onset of the pandemic, and we couldn't get the supplies in time, and people were resorted to use some makeshift masks and gowns and whatnot. And we saw how critical this is to have this in order and have the supply, uninterrupted supply. Operational management and business continuity is the 5th core competency in our framework. And that's Craig's domain area, but we all kind of swing between the different competencies. But this is basically having the plans that are nimble enough and adaptable enough that you meaning the health system, can withstand any shock. Information management system and data analysis. We collectively, in all our environments, we collect lots of data. What information needs to be collected, how we protect that information, how do we do the data analysis, help us to manage this process and help us to forecast the shocks, as well as manage the critical situation that evolved. Assessment of risks and vulnerabilities it's very critical, obviously links back to the forecasting and importance of anticipating shocks, because more time you have to prepare, the better your outcomes will be. And last but not least, training and exercise. I'm a firm believer, and World Health Organization also said that if you want to have a fast response to certain shocks and events, you need to exercise that function at least once a year. So basically means that you need to design simulation exercises, the different kinds of training events, so the people do what they need to do in a crisis. And as a doctor, I always say, if I have a patient in front of me, it's a crisis situation, I don't go look at the manual. It needs to be a muscle memory. It needs to be your gut reaction, exactly what you need to be doing. That's where the training needs to be. You don't have time to think, rather you need to act fast and make right decision. And that's where the training and exercise comes in. With that said, I spoke a lot, so I would like to pause here and transition to my coworkers, and they will unfold and show you and walk you through how this wheel works in the reality, and how do we bring those capacities to our partners, and how do we help them to become more resilient. So with that said, let me reintroduce Matthew with his Kiribati case. So Matthew, please take over.
Thank you, Nino. Kiribati, for those I'm sure most of you are aware, is approximately located halfway between Hawaii and Australia. I think it's about 2,000 miles southwest of Hawaii, nation state, about 125,000 people. And Kiribati particularly is strongly affected by climate change and the like. So we've been doing work there looking at how we can make the nation more resilient. And that includes land reclamation projects. I mean, to give you an idea, the nation, the mean altitude of the country is about 12 foot. So much of the country is sitting about six foot above sea level. So in a health paradigm, what does that look like? At the moment in Kiribati, we have 2 hospitals, and we already have storm surges passing through one of those hospitals where we had, on multiple events, we've had the sea wash through the hospital. And you can imagine that's not really a health system that's sustainable. So we've been working with the government of Kiribati and the Ministry of Foreign Affairs and Trade from New Zealand, really to look at how we can support their health system to be, exactly as Nino said, more resilient, and acknowledging the challenges they have, particularly with the sort of the altitude of the land, of the infrastructure. That includes work we're doing at the moment, which is really to upgrade their health facilities, to provide them at sort of a higher altitude. And that's not significant altitude. You can imagine it's not going to be much, but by adding another 4 foot to the height of the buildings or the ground floor plane of the buildings, all the lights. That is really around new infrastructure. But infrastructure is not the only response. And exactly as Nino said, in a nation such as Kiribati, there's a whole range of other things which need to be looked at. And some of those, we've been looking at some of the risks and vulnerabilities and how the nation can respond to that. So that's including things like their approach and management of pharmaceuticals, and medication being a prime consideration for managing a well-functioning health system. So we've undertaken a range of other sort of side scope missions with the government there, and also looking at some of their models of care and their operational management policies, such that whether they've got the right training programs in place to support their workforce. Workforce is a particular challenge in these types of localities, getting people with the right skill set. So those models have also looked at sort of the whole holistic health system to try and help reinforce the resilience of their health response in the country. I probably could talk about this project for, I'm going to say, hours. I mean, we've been working since 2018 in Kiribati, and we will continue to work with them and support the country for some time coming. But I suppose for myself, the other thing I find really important is the sustainability approach for the project and the like. So whether that's about health sustainability, it's also about building sustainability. So approaches of things like low energy and the likes, particularly for a country that has limited capacity to pay for many of the things that we see as a fact of life in our lifestyle. So how can we add sustainability to the project and to the nation as a whole? I'm going to pass on, I have to say, to the next slide, and I can't remember if it's Craig or Nino coming next. I do apologize. Craig.
That would be me. So thank you. Interestingly enough, a lot of what Nino and Matthew have spoken about, we had planned for this long before with the Rush Transformation Program. So I'm sure many of you have probably read in the media, there's been a lot of media coverage about the Rush University Medical Center, and in particular, this is the East Tower. And there was a vision for not only the East Tower, but the entire Rush campus for having resiliency or emergency preparedness long before the pandemic back in the early 2000. And so I guess that's part of what happens when you combine a former Marine as the deputy director of the emergency department with another, the chairman of the department, who is very visionary in seeing the need for this. So the planning for the East Tower really became an integral part of building in all of the resiliency needs when this was all being developed and conceived. And it was done that way so that it can be operationalized later on. So you're not having to create makeshift negative pressure spaces or bring in emergency power or medical gases or things like that. This was all planned and integrated with the East Tower as part of the whole, as part of the infrastructure. And so that kind of brings me to my next point. With regards to the infrastructure, there was also a significant amount of attention given to the security, the HVAC systems in both the emergency department as well as in the bed tower. And the bed tower, just to give you some reference, it's that butterfly. It's that butterfly shape on the top of the building. It's those 5 floors. And that's what we refer to it for those who might be visiting Chicago or familiar with this space. And then the lower floors, starting with the ground floor, is where the emergency department is located, and then there's the other services. But these this infrastructure was all developed and built into this building. And it was done in such a way, because it was planned in, it was done very economically. In other words, it really it had very minimal cost implications. So, so one of the features that was figured into this, and I'll explain some more of the rationale for doing it this way. We had designed in oxygen outlets, as well as emergency power and data outlets in the columns for the lobby, for the main lobby. So that gave the capability, if there was a surge, that Rush would be able to use that lobby to just open up the floodgates for patients. They didn't have to worry about stringing extension cords and all kinds of things across the lobby. It was all set up that way so that they can flex into that space. And that kind of brings me to the operational management, as well as the ongoing business operations. So when I talk about this, there were multiple layers of reliability built into the response plans. And so really, depending on the severity of the event, Rush has the capability to expand or contract into different spaces throughout the building. So if the event could be limited just to the needs of the emergency department, but in addition to that, the emergency department, where the ambulances pull in, is a covered space, and it's also tempered space. So they also have the capabilities to expand into that space if need be. And then they have the capabilities to expand within their own emergency department. And then again, if it goes further, in the case of our pandemic, they go up into the bed tower, and the bed tower has systems that, with the flip of a switch, could convert over to negative pressure, which is what's happening now with the pandemic. And also they have in the individual rooms, they have the capability to expand their patient capacity within there as well. So there's multiple layers. And then as a last resort, I mentioned about the lobby space, which is what they ended up needing to do because of the severity of the pandemic. So there was a variety of layers that were all built in. And in addition to that, when we're talking about the whole logistics and supply chain, okay, they did not use a just-in-time model, okay, the JIT. They did, they have an offsite warehouse, which was also factored into a series of simulation models. And so prior to the design and planning of this building and the expansion of the campus, we ran a series of simulation models with all different operating scenarios to sort of test the capacity and test where the weak points were. And coupled with that, we also did we went through a series of, and I know many of you are familiar with this, failure modes and effects analysis exercise. And so we spent 3 days going through FMEA with all the stakeholders, everyone from the emergency department through the clinical staffing, security, supply chain. They all participated in this, and it was very, very informative as far as the operations. It identified a lot of those weak points, and it really does tie to what Nino had brought up earlier, as far as as far as really identifying where those potential risks and vulnerabilities are. Right. This was the ideal exercise, combined with running through simulation models to flush out all those situations. And the last thing I'll add is that we also integrated a lot of automation to the operations of the hospital, as well as the rest of the campus. So if any of you have ever visited it, you might see back of house a bunch of robots delivering all different supplies across and up and down the bed tower. So they use it for their clean linen supply. They use it for delivery of food trays. They deliver all of their supplies using the robots. And so what that does is that really does free up the reliability on your FTEs, your people. Okay, so in the midst of a pandemic, when resources and people are limited, or you want to keep them out of harm's way, robots is ideal, and any type of automation. So there's other automated processes and procedures throughout the building, including a pneumatic waste and linen removal system. So just to keep that in mind, that there's a lot of different ways to approach this, this challenge. And so, and lastly on there, as far as training and exercises, extensive training and exercises, and again, to Nino's point, this is something that needs to be instinctual. And so they run every year, once or twice a year, a series of exercises when they're not in the midst of a pandemic with the local authorities. And they do this with the fire department. They do this with the ambulance responders. Everybody who's got a finger in any kind of an emergency response is a part of these training and exercises. And so with that, I'm going to turn it over to Matthew now, and look forward to your questions.
Thank you, Craig. Move the next slide. There we go. Click it on. So I'm going to talk about Roma Hospital. Roma is about an 8-hour drive inland from the coast, from Brisbane, in the bush. It's a relatively small regional hospital, and I think one of the interesting things about the smaller regional hospitals are the capabilities that they have to deliver with relatively small workforce or small facilities. So these facilities, not unusually, they end up receiving a very mixed patient cohort with a very diverse range of clinical requirements. So one of the things we see very much so is the capability to be connected via telehealth back to the main tertiary centres. So we have you can see in the bottom left there, the emergency room department, where every single treatment bay is connected with telehealth back to the tertiary centre. And that goes through the whole facility, whether that's in the OR rooms or the likes. The other things about some of these smaller facilities we find are the maintenance and operations. We end up with a smaller team on site looking after the facilities. How do we simplify that such that the facilities maintain fully functional and operational? And some of the decisions on this project particularly really focused on the operations and maintenance. As an example, all the plant rooms, all the mechanical, electrical, or not all the electrical, most of the electrical systems are located on that upper floor out of the way of the clinical areas. So we've got things like fire dampers that need to be maintained. all of those are located off away from the clinical areas, meaning we have the operational maintenance people able to maintain the facility safely without sort of moving through the clinical areas, which gives us greater flexibility in sort of service delivery and the likes. Some of the other things we looked at, certainly in this project, again on systems, we have a very big issue with water quality. We're using artesian water in this locality, and some of the water treatment in place. We've got patients with dialysis. How do we maintain a stable and safe supply of water? And when we have, certainly in the bush, there are challenges with water. So even having the artesian well systems, some of that water can be, we find the flow is not always consistent over time and the like. So that gives us challenges. The other one you'll probably have heard about or familiar with is some of the bushfire risks. So how does that respond in a health system? And I'm aware we've had similar issues on the west coast of the US with bushfire or forest fire smoke. How do you maintain your health facility when you have that level of potential poor air quality coming into the building? And how do you maintain operational effectiveness and the likes? So again, a lot of work done at that. Roma does have bushfire risk. So again, looking at how the mechanical systems can maintain operation and accommodate that risk of bushfire smoke and the likes. So there were some of the initiatives on this project that we undertook, which really assessing those risks and vulnerabilities. And I guess it's having that holistic view of any project and the like. So this one particularly probably has got a very low risk of flooding, but some of our other projects would have a very different approach to some of that sort of flood risk or the likes. Again, the learnings from things like COVID and would we do things differently? The smaller facilities, to some degree, we have greater flexibility in how we configure the spaces for temporary responses, but it is having that holistic response to the resilience. I'm going to pass on to Nino, who's going to talk a little bit about one of the planning projects we've been undertaking with Mercy. If I can pass on to you, Nino, push the slide forward.
Yeah, thank you. I appreciate it, Matthew. So you see on your screen the work that we did for Mercy Health in the United States. And we've done quite extensive work with this health system in response to COVID-19. And specifically, we looked at their existing policies and regulations and the work that they've done for infectious disease outbreak response, and then did the extensive risk and vulnerability assessment of their locations in 3 different states. And that was the risk and vulnerabilities to their infrastructure as well as operations and how they were like running their operations throughout the pandemic. And we pointed out the certain pain points and also helped them to design certain projects and programs that they are right now in the process of implementation. But what we did in order to do this risk and vulnerability assessment for Mercy specifically, we used the Safe Hospital approach and ranked them using the Safe Hospital Index that looks at different natural and man-made hazards and what are the different types of the adverse events that affect that particular locality, as to Matthew's point. And then we prioritized that, so to speak, and gave the list over to the leadership of Mercy and made certain recommendations, what we thought was more likely to happen and less likely to happen. We also developed their pandemic preparedness plan for all of their facilities. Again, they have multiple facilities. And this pandemic preparedness plan right now is being implemented at the different levels of care. It's a very comprehensive approach, but also can be, what I loved about this, the pandemic preparedness plan that we did can be adapted to the other events as well. So we walk them through, train them how to use this plan in the future as well. Lastly, we are still continuing working with Mercy, and we are building the entire umbrella project for emergency management, resilience, and then all of our like smaller projects will go underneath as strengthening pillars. And we are very happy with this work, and our partners are very happy with our work as well. So over back to you, Matthew. I believe we have one last slide left, Gray Base Hospital, and I believe that's it, right?
Yes, I think so. And we'll leave a little bit of time for some questions. So I know we want to leave about 15 minutes or so. So I'll talk relatively succinctly on Gray Base Hospital. Gray, or New Zealand, most of you will be aware, is obviously a seismic zone. So, and New Zealand in 2011 and 2010 suffered some pretty significant seismic events in Christchurch, which you may be aware of, which really put their health system under significant challenges. Greymouth, Gray Base is on the west coast. It's about a 4-hour drive from Christchurch. And this was part of the government's response to emergency response planning and the likes. The existing health infrastructure was assessed across the country, and not in a dissimilar consideration of what we've seen here also in California about post-seismic events, how robust or resilient is our health infrastructure. Across New Zealand at the moment, we're going through a range of facility replacement programs, and Greymouth or Gray Base particularly was one of those. Again, it's a isolated facility. I said about 4 hours. It involves driving over a transalpine pass to get to the main tertiary centre. And that transalpine pass route is not infrequent to be cut off by snow, landslides, or the other. So it's another facility that needs to be able to run and function on its own as a standalone. I remember when we worked on this facility, working with the emergency room physician, he described it as an elbow. That was his response to a little bit of everything, was how he described it, that everything comes through the door. And then also having to run the facility in a fashion where they may not be able to do any transfer out. We get pretty heavy fogs on the west coast, and you may be isolated here for 3 or 4 days. So how do you stabilise a patient and maintain safe care for those high acuity patients where you can't transfer them back to the main acute setting? So we did a lot of work with the health system around their operational management and business continuity, really because of its isolation. And that went through as far as some of the training and the likes, where we again are getting physicians and clinicians having to undertake types of service that traditionally they don't see very often. So how do we support that type of clinical care? So building in the simulation suites and the likes into these relatively small facilities. We're seeing that more and more to maintain clinical workforce and capabilities. I could talk a lot about some of the engineering systems. Being a seismic environment, you can imagine a lot of seismic control or the likes. But I'm mindful to time, so I'm happily bring sort of us round towards the questions. Does that make sense, Nino? Should we move on to questions?
Absolutely, yes. Thank you, Matthew. Thanks, Craig. And I see a couple of questions and a couple of comments. The question, let's start with Rush University. Based on what was done at Rush University, how do you see this approach evolving in the future in terms of design, operations, and planning? So that's for you, Craig, if you want to expand a little bit.
Sure. So from some of the feedback that we're getting from the stakeholders at Rush, we see this as becoming somewhat of best practices to follow in the future. And it doesn't have to be for a brand new out of the ground type of a building. These practices can be applied to many existing, as Nino mentioned earlier with Mercy. There's a lot of applications to applying these best practices to any type of facility. And so, for example, when you're talking about failure modes and effects analysis, and then having that coupled with simulation modeling, these are all practices that are used outside of the healthcare environment extensively, especially in corporate, because of the reliability and effectiveness of them. So this is something that we see as becoming best practices going forward, as well as preparing for your operations. It's something where you need to have a plan, and you need to go through it and refresh and make sure that everyone knows what the plan is. And so having these drills on an annual basis or every 6 months is really, really critical. And then going to the logistics and the supply chain, automation and robotics, this is used all over the globe, and especially in other industries. And so it's very slow to kind of get traction in the healthcare world, but it is gaining traction, and I definitely see that as a best practices going forward. So I can go on and on about other stuff, but I don't want to take up all the time. So
Sure, thanks, Craig. Appreciate it. And second question is Kiribati. Based on your experience on Kiribati, what resilience and capability can gain from a small health system and transfer to a larger nation or entity? Matthew, that's for you.
Yeah, I mean, I think particularly in Kiribati, because of its locality and how it's one of the nations that's probably has the most effect from the climate change risks. Some of the questions you see about is sustainability and climate change, certainly within regard to the health system. Seeing what we're seeing in Kiribati, where we have actually seen, storm surges passing through the hospital. What does that mean for other health systems? And I talked earlier on about the example of Roma and some of the bushfire or the wildfire smoke. We're tending to see more and more of those sort of types of events challenging as health systems. So I think the experience from Kiribati is the unexpected. We probably wouldn't have anticipated these events occurring. What do they mean as we see more and more of these types of events across different health systems? So I think sustainability is one. The other one, maybe again for Kiribati, is workforce and the capabilities of workforce. One, our major tertiary centres or major sort of cosmopolitan cities have better access to good workforce. What does that mean for our rural or more isolated populations where we do, I think across all health systems, we see challenges in getting workforce and keeping them cognitive or challenged or maintaining clinical capability, certainly for the more unusual events. So the generalists, how they can maintain skills across a wide range of skills and capability. And we've seen that sort of conversation in Kiribati. And we see that similar in some of those other two projects I showed you at the smaller scale of the project. So that range of capability across the world is probably another area I'd talk about, Nina.
Thank you, Matthew. So I see a couple of comments in the chat. Appreciated, Rich, Steve. Yes, I don't know if you want to dive into the wildfire smoke problems that you mentioned.
I can talk a little bit. We saw, I'm aware, I say both in California, we're aware of that concern or consideration on the West Coast on the fires that occurred, I think it was last year, and similarly in Victoria, in Melbourne area, where we saw a lot of our health systems actually had to shut down. They couldn't operate their technical suites, their operating rooms and the likes because of the air quality issues. So historically, we've not had that issue with our health system being able to having to shut them down because of air quality. What does that mean? And what's our approach to maintaining clinical process when our buildings can't actually function in the environment because we hadn't anticipated the level of, whether it's bushfire or wildfire smoke or the likes. And I think, again, talking about sustainability, those types of challenges we're putting on our infrastructure and our systems to respond to the unexpected. I think that's the challenge on resilience, particularly, is we can often respond to things we know about or have experienced, but how do we translate those we may not have considered? I think that's one of the biggest challenges. Actually, have we actually considered all potential risks or the likes? For Kiribati, another one we've spoken a lot about is fire risk in a nation such as Kiribati. Where you don't have a sophisticated fire system, or fire brigade or fire response, how do you maintain or provide a new health facility that is multi-level, that has patients on upper floors, that you can maintain a safe system where, again, operations and maintenance is not necessarily the same as we would see in the US, in Australia or the likes. So are our backup systems actually maintained safely? If we have, fire suppression systems, are they actually going to be operational when required? And some of those challenges are another one that's very mindful to in these types of locations.
Thank you, Matthew. And I have another question coming in. How can organizations like SAMI help advance conversations and public understanding about health system resilience? I'll take a first crack at it. I guess it's a comment that, or the question that can go to anyone on the panel here. At least from our perspective, we have been promoting this topic and having a conversation to raise the awareness of health resilience and importance of resilience in the health industry. We've been talking at the different forums, like we've been talking with the federal government. We'll be taking this approach to the state governments in United State health agencies in the United States as well. And plus, we've delivered a couple of different talks around the world. So how SAMI can help with this, I guess, the organization like SAMI, where we get the different diverse groups of participants, it would be good to continue the conversation. And I know we threw at you all a lot of concepts here, and it's really, it takes time to wrap the head around all different segments of resilience and whatnot. And my suggestion maybe would be for the future, like select a segment and have a panel conversation. What about health infrastructure resilience? What about the governance aspect, and how do we deal with this? So I think that would be probably my suggestion and thought. And I don't know if Matthew, Craig, maybe you want to add anything.
I would echo what you had indicated. I think a deep dive, more concentrated discussion on any one of those topics and beyond is certainly worthwhile. And I would also advocate even having a some type of publication or contribution to even some guidelines, depending, would also be of benefit. That would be my sort of my take on it. And the other thing too is looping in hospital operators, right, and health system operators who will give you also a more their real life take on this. It's not to say that we're not getting the real life feedback from them, but it's always good and valuable to have that dialogue.
Okay, so we are approaching at the end of the hour. Thank you all for listening, and thank you for giving us a chance to talk to you about the topic that we are very passionate about. Steve, Kathy, over to you, unless there are any other comments or questions.
No, thank you, Nino. And I just want to extend my thanks to you, Nino, Craig, and Matthew. We really appreciate this. I know myself as a public health service officer, working with the Indian Health Service, I am by default a water and wastewater guy. But throughout I have been pulled more and more into the healthcare world, with the Indian Health Service clinics that we operate, and knowing and understanding, healthcare operations and resiliency in general helps me understand in my leadership role how to interact in times like this when we have pandemics and everything going on. Because resources are always constrained, and knowing when to ask for additional resources for my program is vital. And so being able to understand these bigger pictures is great. So thank you guys. I know we are running out of time and we like to stick to 1 hour. So unless Kathy has anything else, I want to thank everybody for joining the call today. And we look forward to seeing you guys at our next Health Engineering Task Force meeting. Thank you.
Thank you for having me.
Thanks, everyone.
Thank you.
Goodbye.
Thanks for having us. Bye-bye.